Hello there, I'm Dr. John Rex, and I'm here to answer your burning questions about AMR. There are really only two kinds of trials deep down. Every trial that you do is one where you're either doing what's called a superiority comparison, that is, A is better than B, or you're doing what's called, it's a funny word, a non-inferiority comparison, where we're trying to show that A and B are about the same. And these two ideas are confusing. You just got to say it flat out. They are confusing, and you've got to do a little thinking to get them straight in your head. So let's take them one at a time. In a superiority study, the goal is to show that A is better than B. And B could be an old drug. B could be placebo if there's not a current drug. But the point at the end of the study is what you're hoping is that your new thing, A, is measurably, demonstrably better than B in a group of human beings. And when you do a superiority study and you unblind your data at the end, you say, look, A is better than B. There are actually three things that you've proven. And two of them are really quite subtle. But the obvious one is that A is better than B. That's obvious. That's the result of the trial. But the two more subtle ones are, first, you were able to identify a group of people who needed A. They went from here to here. They got better. It wasn't people with some random disease. It was people who had a disease that you could fix with A versus B. So the study entry criteria identified a group of people who needed A. The other thing you get is how much better A is than B. Why is A better than B? So you can say, well, A was better because people went home sooner, or they're coughing away faster, or whatever it is you measured. But it's something you can write it down. You can say, look, these people got better in a way that was palpable, it was perceivable. And so at the end of your study, you can say to people, who needs it? Well, the people who went into the study, they needed it. What's the benefit that they get? And you've got clear proof of that benefit. So superiority, A is better than B. And the beauty of a superiority study is that it's intrinsically validating. Everything you need to know is in one experiment. When you do a non-inferiority study, your goal is to show that A and B are about the same. And let's just pause for a moment and think about why you might even ever want to do that. Because if you've already got a drug that does this, why do I want another one that does the same thing? Well, it could be that maybe some people are allergic to your drug A. You're going to make a non-allergic version. Or maybe this one's an IV and this one's a pill. So there are reasons why, even if we've already got a therapy for something, you might want a different therapy that does pretty much the same thing. So when you have that situation, two drugs that work, you need what's called a non-inferiority design. Now, the word non-inferiority it's helpful to parse it a little bit. We're saying that not inferior. We're saying that B is not worse than A. B is not inferior. It's up here. It's the same. It's not down here. It's up here. And it's helpful to think about what that idea means. So, two apples. Okay. In the past, we used to talk about equivalent studies. We would say, I'm going to show that A and B are the same. Let's look at these two apples for a minute. Are these two apples equivalent to each other? I mean, they're pretty similar, but are they identical? Well, I can tell you they're not. I'm looking at them closely. One of them still has its stem. They've got different stickers on them. But from the standpoint of being an apple, are they the same? Well, actually, yeah, they are. I can tell you they both smell pretty good. I actually had one earlier today. It tastes pretty good. So from the standpoint of being meaningfully similar to each other, that is, is either one of these an inferior apple? I'd be happy to have either one, quite frankly. They are functionally similar, but statistically, the phrase we use is that they are not inferior. These two apples are similar enough that we don't care about the residual difference. Most of the time, if you can, you prefer a superiority study. It's just so much cleaner. A is better than B. A is this much better than B. Here are the people who benefited from getting A rather than B. It's just so clean. But there are times when what you want is a B that has the same efficacy as A, but has some other properties. And let's think of an example real quick. A new drug for migraine. What if I told you that I had a new drug for migraine that you could carry in your wallet, and at the instant you had a migraine, you put it under your tongue, and 10 seconds later your migraine's gone. And I say, I think I've got this new drug B for migraine that I think is going to be, it's going to work. It's not going to work any better or worse than the old drugs for migraine, but the cool thing about it is going to be how you use it. So the old drugs, whatever their property is, but my new drug, it's this cool, slick, really, really quick thing. And that's a case where I'm never going to show that B is better than A, because once you've made a migraine go away, if therapy A, the existing therapy, makes the migraine go away, I can't be better than that. There's no better than gone. But what I do want to know is that my new drug is about the same as my old drug. So this is where we do this non-inferiority design. And so you could imagine doing a comparison like that for migraine. But actually, migraine is a special case because, in fact, I could actually do 3 arms in a migraine study. I could do old therapy, I could do no therapy, and I could do the new therapy. You can actually include a placebo in a study of migraine. And you would include a placebo because it would actually validate the whole design. If you had the placebo arm in there, you'd be able to say, look, the old therapy did about what it was supposed to do. The new therapy did the same amount. That all kind of lines up. And you really can clearly see that the new therapy is better than placebo and about the same as the old therapy. And that's really a really useful design. And migraine would be a case where you could do that because migraine is a severe headache. Okay, and it's no doubt it's a severe headache, but it didn't kill you. And the worst you could say about if you were willing to participate in this trial with these 3 imaginary arms is that if you got the placebo, your head would hurt a little longer than it would otherwise. But if you're somebody with a migraine and you've listened to me say, well, if we succeed, you, migraine sufferer, one day will have access to this really cool new way to treat your migraine. You might say, look, I'll do that once. It's one episode of migraine. I'll volunteer to be in your trial. The downside to me is if I got the placebo, my head hurts longer. You're willing to do it. When we do antibiotic trials, we're talking about diseases that are really pretty dangerous. The pneumonias, for example, can kill you. If I don't give you an effective therapy for your pneumonia, you could die. And it means that when I do a clinical trial of a new drug for pneumonia, in order to get you to be willing to be in my trial, and actually for me as your doc to be willing to put you in trial, I've got to believe that the 2 arms of the trial are both going to work. The goal has got to be to always give you something that works. And because of the danger of infections, the fact that they can kill you, we do not ever knowingly offer somebody non-therapy. We would never do placebo. And if I thought that the old drug, the comparator drug, was likely to not work, if I had evidence from the lab that your bacteria was resistant and it wasn't going to work, I wouldn't put you in the trial. That would be an exclusion from the trial. So when I study a new antibiotic, I always want to be in the case where I've got 2 therapies, both of whom I think will work, the old therapy and the new therapy. Now, you might say, ooh, wait, I thought antibiotics were about new drugs for bad bugs. There's these resistant bacteria, right? Don't you want to develop the new drug for the resistant bacteria? Well, yeah, you do. There's a trick. Imagine that I'm developing a new drug for resistant E. coli. Okay? And in the laboratory, I can show you that the old drug doesn't work for the resistant E. coli, and the new drug does. And I can do that in a petri dish. I can do that in an animal model of pneumonia. And I can show that the old drug doesn't work, the new drug does work. Now, at the same time, both drugs would work for an ordinary version of E. coli. So a plain old, not resistant strain of E. coli. Old drug works, new drug works. They're both going to work about the same in the animal model and in the dish. It's the difference lies in the ability of the new drug to work when the old drug doesn't work anymore. That's the difference. The difference is in the laboratory right now. We hope there aren't very many strains of the really bad resistant bug out there. There are a few. That's the reason we're developing the new drug. But they're not terribly common. At least that's what I'd hope. I'm going to try really hard to make that be the case. But I still want to develop the new drug. So what am I going to do? Well, what I'm going to do is find people who are infected not with the uber resistant strain, but with the ordinary strain. Because in an ordinary E. coli infection, the old drug works, the new drug works, and I can say to you, look, would you be in my trial? You've got pneumonia. Your pneumonia is due to a bacteria. I could treat with the old drug. New drug looks like it's going to work too. I'd like you to be in this trial. And I think intelligent people can look at that and say, yeah, I'll participate in that study, because you're trying really hard to avoid giving anybody a therapy that you know won't work. And the key is that you know that in the future, when resistant bacteria appears, old drug doesn't work anymore, new drug will still work, because that's how we picked it out in the laboratory. So that's the key, is that in a non-inferiority, in an antibiotic study, I'm not willing to deliberately do a superiority design. I'm not willing to deliberately give you placebo or deliberately give you an ineffective therapy. I always want to give you two good therapies. Either arm, both arms should work. This has confused a lot of people, because they will say correctly, I thought I wanted a new drug for the bad bugs. Show me some data with the bad bugs. Please show me how it works in the bad resistant infections. Well, when you are developing a new antibiotic, you actually tend to do two categories of trials. It's something that I've done. You do trials where you study old drug and new drug in settings where both should work, and those are your big trials, and your goal is to get a lot of good data there to show that the new drug works about as well as the old drug when they both should work. And then you also do a separate study where you make the drug available to people who are in trouble. So in that setting, which you either don't, it's not even randomized. You just look for people who have bad bugs. They've run out of therapies, and they come to you and you say, look, here's the Hail Mary pass. You can give this a go. Or you sometimes do a study where the other arm isn't one thing. It's something called best available therapy. You invent whatever you can do that you think ought to work. You run it against the new drug. And those studies, you can write them down on paper, but in fact, they're very hard to study. The ones where you're looking for the Hail Mary pass or the best available therapy versus new, in part because we work so hard to make resistant bacteria uncommon. And at the clinical trial sites where my new drug is, and new drug is not available at every hospital in the world, it's only available in investigational sites, certain locations. Those tend to be sites where they've worked hard to make resistant bacteria uncommon. So the experience is that when you set out to do a study where you say, I want to enroll patients with resistant bacteria, it's like chasing the Phantom Menace, because the hospitals that have had resistant bacteria get busy and try to make it go away. Another way to look at it is that no hospital wants a sign out in front that says, World's Center for the Study of Super Resistant Bacteria. We've got them all. But don't worry, come on in, because we've got these clinical trials. No. Nobody wants that sign. A Center of Excellence for Multi-Drug Resistant Bacteria? I don't want to go to that hospital. I want to go to the hospital that is keeping its resistance rates down. And that's where you have to study the new drug. You have to study the new drug in that setting. You have to deal with the fact that we work really, really hard to make resistance rare. Superiority and non-inferiority are our two key trial designs. When you can use a superiority design, it's cleaner, it's clearer. We should do that. Non-inferiority is about showing that two things are about the same. It's messy. It's not as satisfying. The reason why you need the new thing is not clearly shown in the study. The reason you need the new thing is because there's some other feature that you can't show readily in the clinical trial, but you know is out there. And in the case of antibiotics, the feature is that we know from the lab that the new drug maintains its punch, still works when the old drug fails. But I don't want to show that in human beings. I want to show that in the laboratory. It'll still be true in human beings when the resistant bacteria become common enough to be a problem in human beings. And I'll have the drug in advance. That's the key. Superiority, non-inferiority, that was a lot of stuff. I don't know about you, but I am exhausted. And it's helpful to read about this. And so there's a newsletter that talks about why we need non-inferiority. It's actually called In Praise of Non-Inferiority. It's a weird idea. Take the time, go read about it. There's a link in the description below. Find the newsletter, study the problem, understand it, and thanks for listening.